Hello. Right, so welcome everyone to the, I think it's the 40th governing body meeting being held in public. I've got a few messages that I need to read out first of all before we come on to the agenda proper. So in relation to questions from members of the public, the CCG is committed to a process of openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. Although the meeting is held in public, it is not a public meeting. This means that there is no opportunity for the public to ask questions apart from that offered at the chair's discretion. There is a specific slot also at the end of the agenda. The governing body meeting is also being video recorded as part of the commitment to make information as accessible as possible. The video will be put onto the website within a few days of the meeting. The CC just does not allow any other recording of the governing body unless agreed to prior to the meeting by the chair. And the CCG has a protocol setting out how it will conduct its meetings, and this is available on the website. So if we can come to the agenda proper, I think that everyone's got name tags, so I'm not going to go round introducing people unless there's any need to at this point in time. And if we can just make it quite clear that if you've got mobile phones, if you can just switch them off or put them onto silent. And if I can just ask members of the board, are there any conflicts of interest pertaining to items on the agenda that have not already been declared? No? Okay. Right, so if we can just come to the minutes of the 39th meeting. As regards matters of accuracy, so if we can go just down page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and 14. Okay, so if we can sign those off as an accurate record. We've got a couple of actions that have come out of the minutes. The first one is at the bottom of page 13. It was agreed that once a response had been received from the Autism, the ASD service, it would be circulated to all governing body members for information. So, Julia, has that been done yet? Sorry, the action at the bottom of page 13 says it was agreed that once a response had been received from the ASD service as regards the delays within the system, that they would circulate the response.
What we've done is we've dealt with the matter directly with the parent who raised the issue directly, and we've dealt with that, and myself and Dr. Moore are due to meet with Mum. I will pick up that other action. Sorry, it had completely fallen off my list of actions, so apologies.
All right, thank you. Sorry, sir, yes. And that was exactly the reason for trying to look into this and actually provide some information back. Okay. And at the top of page 14, there was an action point around providing the member of the public with a copy of the Thrive Kingston strategy. Do you know whether that's been done?
Again, we can pick it up. We make sure the whole of that action has been taken. Okay,
thank you. All right, so if we can come to if we can come to any questions pertaining to items on the agenda that people wish from the public, so that we can take that into consideration when we come to that item. No? Okay. So the items that were taken in private on the 4th of September were around the decision for a collaborative decision-making committee in common at South West London. This was agreed, and there has been a committee in common meeting, and I think that some of the agenda items were around health place-based safety. and the minutes are actually on the agenda itself. So that was just for noting. So if I just go through to the CCG Chair's report. I've got it here. Sorry about that. So I just wanted to touch base on three or four different things. Okay, the first thing was around the local area. So outpatient transformation is still progressing in 5 different areas with the trust and with the commissioners and also with primary care. We also have looked at this across South West London in the Planned Care Forum, and we're still progressing with the MSK rollout and also the ENT piece of work on planned care. Just of note, I'm not sure whether we discussed this before, but there is a new chair of South West London Health and Care Partnership. It's Cheryl Koppel, and she used to be a chief executive at one of the local authorities, not within South West London, but has got some South West London knowledge. So she's taken over the chairmanship of the Health and Care Partnership at South West London. At a London level, we've had meetings with Chris Ham looking at the meanings of integrated care service, integrated working, and the ways of actually bringing staff along the journey with us. We've also been looking at outpatient transformation at a London level and have looked at information that we need to provide to Simon Stevens and Ian Dalton around the progress of the transformation of outpatients. We also had a London Health Board conference a couple of weeks ago with the Mayor and Simon Stevens, and looked at the actions that have been taken across London, such as things like mental health, homelessness, digital, etc. There have been a whole load of variety of different pathways that have been looked at a London level. And on a national agenda, there have been a couple of meetings to do with the NHS clinical commissioners, and also the STP and ICS leaders and clinical leads meetings, looking at the direction of travel for the future, looking at the long-term plan that is going to be coming out, hopefully, I think, at the beginning of December, which will give us a bit more guidance around the governance view of the direction of travel for the NHS and care systems. So that's all I was going to say on the Chair's report. So, Sarah, do you want to give an AO?
So, as part of my accountable offices, I was just going to just expand a little bit on the meeting that Naz and I went to around the Integrated Care System, or STP leads meeting across. That was a national meeting. One is that on my reflection, I don't know if Naz agrees with me, what that said to me was actually the work that we are doing locally is the right type of work. So the work on the local health and care plans, which we're going to talk about later, and us developing a bottom-up approach to how we look at the whole system is actually the direction of travel for the future. And when we receive the new forward view for the NHS and care, what that will say to us is, can we move those plans faster, and can we work together differently in the system, move away from what was a commissioner and provider split into looking at actually what's the total amount of money that we have for the system and how do we deliver the absolute best services for our populations on that basis. So we are doing that work locally, and I think we are sort of quite well ahead on that. So I think when we have to produce our new plans into next year, we will have progressed that quite well, and we're going to talk about that later. So I think that was my reflection. And also I had a lovely holiday. I was just going to say that as well. So I'm just back from holiday.
Excellent, thank you. Are there any questions around what Sarah's just brought up around the ICS bit? No? Okay, so Tonya, do you want to come up with the MD's report, please?
Thank you, Naz. Just a few items to note in my reports this time. Health and Care Plan, Julia is going to give us an update of where we are on the production of the Health and Care Plan. We've talked to members around the plan previously, and so Julia will give us a full update of where we got to. One of the things I wanted to bring to the members' attention today was an engagement event that we are scheduling for the 21st of November. That we are inviting around 180 people, including health and care staff, local people and representatives from different community organisations. And that a purpose of that event is to really start to explore with that those invited people our case for change and the priorities that we have identified, and the outputs of that event will help develop our health and care plan. I would stress that's not the only engagement we're doing on the plan. The engagement on the plan is continuous, but this is quite an important, quite a large event, and unique in the fact that it brings frontline staff together with the public to talk about the emerging priorities for the health and care plan. Moving on, in my September report, I described the latest position around over-the-counter medicines, but since then we have developed communication materials for GPs, pharmacists, NHS trusts, councils and schools and patients, and they will be launched in the autumn, and this coincides with the winter messages that patients will be hearing and shortly through national and local media outlets around going to pharmacy at the first sign of illness and keeping a stocked medicine cabinet at home. We also talked about the approach around over-the-counter medicines at the recent educational half-day for GPs. Moving on, Naz talked about the outpatient transformation work that we are taking forward in Richmond and Kingston and across all NHS organisations, and there was a launch event on the 17th of October which I opened with Anne, and it was really great to see so many people in the room really talking about what real transformation around outpatients that we aspire to in Kingston Richmond, and building on the work that Naz described. So I think that was really, really encouraging, and I look forward to seeing the outputs of that work over the coming months. We had our annual general meeting in September in this room. Thank you for all those who attended. I think we had a really good attendance, and we had some really insightful feedback around how children and people looked after children and the work they're doing around mental health. So that was really good, and I thank Vicky who came to give us the presentation. We also are pleased to be part of a national campaign looking at loneliness and the importance of social connections, and hopefully members would have seen a couple of weeks ago the government published a strategy for tackling loneliness in England, and they also launched the work they're doing with Royal Mail called Safe and Connected, and I'm pleased to say that New Malden is one of those pilot sites nationally, and Annette is quite heavily engaged in that piece of work. So any questions on that? But it's really good that we are part of a national pilot for that loneliness and importance of social connection, so that's really good. And then finally, just to inform the governing body, we have appointed an interim director of transformation for Kingston and Richmond CCGs. He is David Stout. He's not here today, but I'm sure you'll get a chance to meet him over the next coming months. He's coming here for 6 months, really probably more focusing on Richmond than Kingston, but obviously because there's some synergy about the work we're doing, there will be some overlap, so you'll have the opportunity to work with David over the coming months. So that's all I had to say on my report today, but happy to take any questions or points of clarity.
Great, thank you. Any points? Catherine.
I was just going to say, Tonya, that just from a personal note, my mum lives down in Wales, and she's considered to be quite frail and older now, so she wouldn't agree with me. But what I was going to say is that she's actually been part of this in Wales, and it's been incredibly helpful and supportive. So I was just going to say that actually from a personal side, knowing somebody who's participated in something like this, it's really had a kind of positive effect on her. So it was just to share that back, really.
Okay, thank you. Any other comments or questions for Tonya? No? Rob? Okay, thank you, Rob. I think that given it being a pilot, that we are actually going to get some feedback as we go along. Annette, was there anything else you wanted to add to this?
No, just to say that it is a 6-month pilot. It is being very carefully evaluated, you know, we're interested to see what the outcome is. It has worked very successfully in areas where it has been sort of initiated previously, and I think if it works well, it's something that potentially could, as Catherine said, offer a little bit of security, a little bit of help to people who are lonely and isolated. Yes, no, we're aware of that, and that's why it's being piloted in London as well.
Okay, any other comments or questions from the board? Sorry, do you want to...
So it's not an open invite, it's 180 people being selected and invited. So some of that's recruitment of the public, some of that is frontline staff, and some of that is organisations. So it's not there's not a mail shot going out to the general public around it. But that's why I stress that this is not the only opportunity we will have to engage with members of the public. This is just one event we've got. There is a whole communications engagement plan, but this is very much seen as an opportunity to bring together frontline staff and people that we usually don't talk to. So we're actively recruiting different people to come and talk to us around their concerns around health. So we are recruiting through a specialised company, actually different people to talk to about because we talk a lot of very familiar faces, and we want to talk to other people. But I absolutely won't be the only opportunity we have to engage on this.
Thank you. Okay, unless there's any other comments or questions for Tonya? No? Okay, so Sarah, do you want to give us an update on the South West London Healthcare Partnership?
So you've got here the second update that we've sent you, and we're going to make sure we do this at every governing body. And I'm not going to go through the detail, but I will pick out one or two areas just to highlight. So we've already talked about the November events around the health and care plan, so I won't go through that again. I did want to pick out, because I always want to pick out the children and young people's mental health work, because it's a fantastic piece of work across South West London. It's a priority that we identified together, and we have bid, as you know, for money for 3 of our boroughs in South West London, but we have made an agreement across the CCGs in South West London to roll this piece of work out across all 6 boroughs. So we have got the agreement to do that, and we will be starting that work very soon. And it's about tackling support for our young people in 3 different areas. One for the young people themselves, one around their parents and their families, and another around teachers and schools. And we're taking a whole school approach around that. And we're taking some of the best practice nationally and learning from lots of discussions that we've had locally with lots of organisations that are involved in supporting young people who maybe are struggling, particularly those that are self-harming. So it's a great opportunity for us in South West London to be forefront in this, but also we all recognise, and I have to say this is the only priority that I think we've done in South West London where everybody has agreed that this is a priority and that is something that we should do. So I'm sort of really pleased that we are doing this. So please get involved in that as we go forward, and I'm sure there's others around the room that can talk more about what we need to do than I can. The other area was just around the workforce, because I think we have recognised there is more we could do to deliver our pledge to make South West London a great place to work. And what we want to do is retain staff in South West London, not necessarily within all individual organisations, but also to support people to work within the NHS in South West London by finding different routes for them to come in. So one of the areas that we have developed is a South West London Academy, where we can make the absolute best of apprenticeships locally and how we can work together differently. We're also looking at a passport, so that we can have staff, if they take their mandatory training in Kingston Hospital, will mean that they could go and work in Epsom St Helier and not not have to do the mandatory training again, which I think is a very positive way forwards. We did actually have a discussion in Richmond about, you know, making sure that we roll that out into, say, general practice and other areas as well. I think it's more complex, but absolutely is the right thing to do. So we're at the start of this, so I think we can start to progress this together across South West London. What we don't want to do is take away from individual organisations and their own ability to recruit and to retain staff, but this is about those things that we can do together at scale that makes sense. So we're doing work together across South West London in that area as well. There's lots of information on here around end-of-life care and connecting care as well, and what we will try and do is bring you a report back every governing body with different areas, but you know, children, young people, mental health are a really big opportunity for us in South West London, I think. And we're very hopeful that we are going to get the national money, but we haven't heard yet.
Have we got a date for that?
Any time now is my understanding. Just waiting in anticipation.
Right, thank you. Any comments or questions, Catherine?
Thank you. So thank you for that. I just wanted to kind of point out around the primary care piece, particularly around the nursing and then allied and wider professionals moving into general practice. It would be really useful, I think, to sort of ensure that we engage those primary care nurses and that it also goes and aligns with the GPN 10-point plan and the regional delivery boards to ensure that actually we do it once and it's meaningful and people feel that they've had an involvement in terms of how we shape it so we get it right. Because I think some of that detail sometimes can be lost. So it's about ensuring that really we kind of connect those dots together. And the other bit I was just going to make mention of is when you looked at children and young people and the whole schools approach. I'm mindful that Kingston in particular and other areas have high levels of independent schools and about kind of ensuring that actually they're represented, because sometimes they are sitting on the periphery of that and don't necessarily engage in the same way. So it was just a plea to ensure if that's the way forward.
I can confirm that we are, and that we have had independent schools as well as state schools involved in this process with us. It's actually been more difficult to engage with them, but we have engaged with them and they have been involved in some of this. Not necessarily all the ones in Kingston, and we'll have to roll it out in a way that makes sense, I think, for all schools. But yes.
Okay. Any other comments or questions around the STP update? No? Okay. Right. I think, Yarlini, are we coming to you for elective activity oversight?
Yes, thank you.
Thank you.
So the report that you have in front of you is the elective activity oversight report. It's a South West London report, but I'm going to concentrate on Kingston. So as some of you might know, as part of the operating plan this year, there was an expectation that the total waiting list, or patient tracking list, PTL, is maintained to at least the levels of, as of March 2018. There has been an increase in the total levels of, or increase in the waiting list, and this has been seen nationally, and actually we've seen quite a lot of increase in London. So the purpose of this paper is to inform Kingston's governing body of the increases that we've seen locally and the range of actions that we are taking. So on a good news story, despite the increase, both Kingston CCG and Kingston Hospital have maintained the standard of 92% of people being seen within the 18 weeks of referral. However, there has been an increase in the PTL, which you can see on the very red slide 4 that's included within the pack. So between the end of March and the 31st of August this year, Kingston CCG's PTL increased by 17% and Kingston Hospital's increased by 21%. So what we've put in place is some actions to understand the levels of increase that we're seeing. We're working with Kingston GPs to look at demand management. And actually, if you look on slide 2, I think it is, you can see that the GP referrals at the end of August was at 4.3% increase. That's actually come down in September, which is good news. It's going in the right direction. And I think a lot of the work that the primary care team are doing in terms of the information that all practices get through the the BI packs that go out, the referral management that goes out, understanding the peer reviews and looking at all of the data that we have had has helped. I mean, a lot of those increases that we've seen in referrals are actually cancer related, which we were expecting anyway. The other thing that we are doing is we're working with Kingston Hospital. We are really assured by Kingston Hospital because they have a robust operating PTL. They have visibility of all the patients that they've got, and they ensure that they've got a chronological booking system. We are waiting from a work plan from the hospital, and this is to ensure that they meet their trajectory by the end of March 19. So we're working with them to do that. So that's all I was going to say, but I'm happy to take any questions.
Okay, thank you, Arlene. I've just got just a couple of queries. Have we got any idea as to the reason why the August went up significantly in the referrals?
So no, actually, the August has come down now. So if you look at the run rate from the 1st of April, we were, I think, in April and May we were at 7%, and then we came down to 4.3, and now we're actually about 2. So it's going in the right direction. I think the first few months actually did peak. There was and you could say that was the backlash of the year end moving forward, but it is coming down in the right direction.
Thank you. Did you say that the peak was mainly around cancer related and breast?
So there are predominantly, when we delve deeper into the information, the growth in referrals are primarily due to the cancer 2-week waits, and we've seen rises in dermatology and urology, and smaller increases in breast and colorectal surgery. But what we can assure the governing body is that the next IGC meeting, we are bringing a more detailed paper to share with members, which will give further clarity on some of this.
That'll be really helpful, because I think that needs to be probably picked up in the outpatient transformation piece as well, about the appropriate referrals going in as a 2-week wait as well. Right, any other comments or questions on the paper from Yarlini? Gareth?
It was just one quick point about the 2-week referrals and routine referrals, and whether the new ERS services, there doesn't seem to be any way of referring people urgently for non-cancer queries. And whether, I'm just wondering whether there may have been an increase in patients put through the 2-week pathway because there's no facility for them to be seen urgently, when maybe where they couldn't wait 12 weeks, but there's nothing in between those 2 points. I'm maybe not explaining myself very well. But I just wonder whether that may have happened as ERS numbers have increased over the summer, and whether that could be looked in, particularly as you were saying about inappropriate referrals, but just ways of getting people seen.
Okay, Phil?
Just to say that working across South London, I have come across that on occasion, so I think it is being used at times. What I don't know is how frequently.
So, sorry, David.
Can I just ask about the Croydon situation? And the report refers to extensive repatriation work that they've been carrying out. What lies behind that? If it is what I think it is, it's presumably a one-off, and therefore this number will come down, or is it actually a continuing pattern of referrals in Croydon, which are impacting on this total for us? I'm looking at both Yarlini and Brian in the audience.
So the Croydon repatriation is focused on 2 areas. One is repatriation from Kings, because there are a number of referrals that go through to the Kings site that Croydon think could be better dealt with locally. This is about how do they get the level of activity that they need as a trust in order to make themselves financially viable. The other area is the private sector, because there are many referrals that go through to the private sector, particularly in Croydon, where they think those could be dealt with within Croydon. So they are trying to repatriate those into Croydon healthcare. So those are...
So just for clarity, there's no direct impact of that on Kingston?
No, but there is, so the only impact we've got around RTT and the way in which we are managing across South West London is that you will be aware that we've got a backlog of patients at St George's, and what we have done is we've set up a, it's actually based in Croydon but has nothing to do with Croydon as such, but we've based we've got a joint referrals unit there, which what they've done is they have taken those patients that they think could be seen in other trusts, so they've got the capacity to see them, and they have put them through the joint referrals unit and offered them an alternative to go to either Kingston or Croydon to be seen. So there is an impact in the respect that Kingston may be doing some more activity that's associated with St George's Trust, but they're only doing that when they believe they have the additional capacity available to do it, which is why we've got the joint referrals unit.
Okay, any other comments or questions? So if we are going to bring back a more detailed report around to the IGC, it might be worthwhile actually looking at what Gareth was talking about as well, so actually we'll be able to populate that around the ERS.
We've got a slide on that we can share with Gareth, and we can also look at some of the long waiters that have come from St George's into the hospital. Yeah.
Okay, thank you very much.
So
yes,
I'm just going to add that the cancer two-week wait referral pro forma should steer you in the direction of the right clinical indications for them to be referred through that route. Patients who are referred by a non-cancer pathway, it can be indicated on the referral form that you'd like to have an urgent slot, and the patient's referral is triaged by the clinical teams. And I think one of the advantages of the system is that you're able to see what some of the slot availability is and helps make choices about where the shortest waits might be within different specialties at different localities. But so completely accept that there's still some work that we could do to help that position, but the two-week wait referral should be exclusively for the cancer two-week waits.
Okay, thank you, Fergus. Any other comments or questions? Okay, so Fergus, I think we're coming to you for the 2018 winter plan.
Thank you, Chair. So the purpose of this report is to provide some details for the governing body on the Kingston, Richmond and Surrey Downs winter plan that we've been working on over the course of the summer through our local accident emergency delivery board. And thank you to Naz as our clinical representative on that board as well. I've put together in the pack a couple of slides focusing on the headlines of the winter plan and a couple of slides relating to our communication strategy. There is a link within the document which would take you to the full winter plan, which runs to in excess of 100 pages, so it was for brevity that I didn't include within the full pack today. Winter is a difficult period of time in the NHS, and I think it's fair to say that we're planning for a challenging winter. Our winter plan is assured through the A&E Delivery Board. It's here for your assurance today, and there are a number of other measures that will be taken over November and December for us to make sure that we're heading into winter in the best possibly prepared situation locally. And those assurance meetings happen through South West London at the Urgent Emergency Care Board and again through NHS England. In terms of the winter plan itself, it's helpful just to remind the governing body the areas that the A&E Delivery Board is primarily focused on. So, of course, to make sure that we have a safe and stable urgent and emergency care pathway for patients, and that includes all parts of the system, including primary care, mental health and other services. We anticipate, as we often experience, a growth in demand during the winter period. And we intend to ensure that we deliver at least a 90% performance against a 4-hour waiting standard. We have worked a lot in the local system together on reducing length of stay for patients, and that is a key strategy for us in the coming winter as well. Improvements have been made over the past 12 months to support urgent and emergency care, and I've listed out a number of those on the next slide. But it includes things like the 7-day frailty service that we now have at Kingston Hospital, the extended primary care access that we enjoy within the locality, and a lot of focus on some of the pathways out of hospital for patients, reducing delayed transfers of care. In terms of our priorities, as I've mentioned, a lot of the work that we have done has been focused on pathways out of hospital. So when patients are ready to go home, that we make sure that services and support is available for them as quickly as possible. And that relies on responsive community and social services partners in the local system. We will operationally support the Trust during the winter period through something we call the Silver Command, which is senior officers from health and social care and the Acute Trust working together on two particular periods of time when we know that there's often pressure in the system. So in the build-up to Christmas, and then in the period from Christmas through till about the middle of February. We will establish review how that is working at that point in time, and we'd of course continue that if that was necessary. A big part of the work that we're doing in terms of our strategy over the winter is about keeping our workforce well as well. So the flu campaign for our staff to receive vaccinations, we historically do well in that regard, well north of 70% for all of our providers. We'll continue to focus on that in this coming year. The second part of my slide deck then just builds upon some of our communications and engagement strategy that we have supporting the winter plan. And importantly, we will be working not just in partnership with the South West London communications team, but also Health Watch, the local authority, the voluntary sector, and using our own staff as well as part of that, with a focus on some of the behaviour changes that we need to see within the system to make sure that people access services in the right way at the right time. Some of that is focused on prevention, and flu vaccination is a key strategy within that. We've talked a lot in the last 12 months about self-care and the importance of self-care. And then in terms of redirecting, it's about getting people to the right point of care when they need help. You'll see that our local campaigns will mirror many of the national campaigns, and that's important that our timing and our messages are delivered at appropriate intervals. There's a focus on helping people to stay well, so that would focus on things like ensuring that the house is warm, being aware of when severe weather is coming, using and making use of your pharmacists, and your local pharmacists are an excellent source of advice and support for people, and a lot of focus on the uptake of the use of the NHS 111 service, which is, again, a fantastic way of getting advice and information, but also additionally they can help now with appointments being booked into our urgent treatment centres, for example. We will, of course, use a range of tried and tested strategies around improving our communications or delivering our communications and our key messages. We will rely on, in addition to paper materials and flyers through, for example, our local notice boards, but also social media and digital media. And an important strategy that we've talked about within the CCG is using our own staff as key people to deliver important winter messages. We have over 100 staff who work within the local delivery unit, and each of us has the opportunity at various points in time when we're out and about within the local system to talk positively about the approaches for winter, but also reminding people of, for example, the importance of having their flu vaccination. More locally, at the A&E Delivery Board at its last meeting in October, we identified there were a couple of areas that we particularly wanted to focus on within the Kingston locality. One being the children under the age of 5 group, and the other the adults over the age of 75. And again, there are two areas where I think we have more work that we could do to help support their access to accident and emergency, to primary care, to urgent and emergency care centres. So in terms of our communication and engagement priorities, as I say, it's about increasing the flu vaccination rate, particularly in target groups, to increase the number of people seeking advice early from their pharmacists. We continue to promote the paediatric service at Teddington Urgent Treatment Centre, where we have 4 very excellent clinical nurse specialists who are skilled in the management of paediatric ailments. Continue to promote the well-utilised extended hours GP service with a particular focus on Chessington, and to make sure that we use that to its fullest capacity. to increase the numbers of people calling NHS 111. And then in partnership with the local authority, some of the things that I think are sort of fall onto the second tier of things to do, but important things like gritting and management of roads and footpaths and the like, access to winter fuel grants and reminding people that there is support available financially to help them keep their houses warm over the winter period. So in summary, I think we're well placed with our winter plan. I think we have a lot of work to do together in the health service over the coming winter period, and I'm happy to take any questions.
That's great, thank you, Fergus. There's an awful lot of work that's gone into the creation of this plan from a whole variety of different providers and commissioners, going right the way across the board from a variety of different areas of Kingston, Richmond and Surrey Downs. So I think there's an awful lot of effort, and actually we've brought together a very good plan on this. So thank you, Fergus. So Nadeem.
Thank you. I just got two questions, really. The first one is around the extended primary care access, and it's only available to patients who are registered with a GP, the local GP. Is there, because typically for emergencies encounters, something like 15 to 20% of patients attended in emergency department are not registered with a local GP. And they seem to miss out on the services that are being provided. So can we not look at as a South West London sector, because patients don't respect the geographical boundaries, so they attend whichever hospital is closer to them, or they'll feel that the need will be met. So can this service not be extended to patients who register with GP anywhere in South West London?
So just to be clear, the services that we have in terms of pre-bookable is through registered patient list, but appointments on the day and attendance at the urgent treatment centre is for anybody who's not registered. So we would be happy to see people in our primary care hubs, whether they're registered or unregistered, for the walk-in on the day appointments. So that applies to all out-of-hour services as well, is it? Okay.
I've worked where there has been that level of unregistered patients before. I'd have to check, but the demographics of Kingston and Richmond would suggest that probably more people are registered with the GP.
No, they're registered with, but they're not registered with the local GP. So Richmond and other areas, Croydon.
Most of our patients tend to be registered within the geographical area. So if you remember, the registered population of Kingston is significantly higher than the resident population. So we do. I think the demographics are slightly different, because I have worked in a city kind of environment, and the demographics are different. And also, I think London has complete coverage of 8 to 8 access now. So what we described in our extended access is replicated across South West London and London. We'll look at the unregistered piece, but there is not as high a number of unregistered patients.
There are some of the ones who are registered but not with a Kingston GP.
But again, I think most people tend to be registered in this area with because we've got 30,000 difference between resident and registered population for Kingston.
I think your question is there a service for an unregistered population? And from what I gather
I think the question
Fergus,
that Nadeem was saying is that there are people who attend Kingston Hospital who are registered with GPs outside of the Kingston area. Yeah. We do record, Nadeem, the people who go to the GP extended hours service who are not registered with Kingston GPs. So that information is available, because I saw it on the last report. And there are a number of patients who attend who are not registered with Kingston GPs but are registered with GPs elsewhere. So the service is open to them.
Okay, all right, okay.
All right, thank you, Annette. Right, any other comments? Naim?
Thanks for the report, Fergus. Flu vaccines. There's a major problem with supply for over 65 flu vaccines. By this time last year, in our practice, we had vaccinated most of our over 65s. This year, we've only done a small proportion of them, and we're still uncertain about our long-term supplies. I think in the area we're fortunate that flu numbers have not started to rise yet, but I'm not sure of what action is being taken to get this supply into the practices as soon as possible.
So it was part of a NHS England strategy that the flu vaccine would be delivered in 3 separate tranches of supply. It was for practices to identify their patient lists and vulnerable groups back in February, indeed, in terms of making and placing their orders. So I'm aware that there are some areas where there has been a challenge. We have staff who are happy to support and work with an individual practice if they have a group of patients and clinics that have been booked and they have had a shortfall of vaccine, because we have been able to sort that out within our locality, whether it be through another practice that might have a surplus by comparison, or community pharmacists. So if there are challenges that you're experiencing in your practice, then please do let me know, and I can get a member of the team to support that. But I think part of the national delivery programme was aligned with the manufacturing programme as well. But it was very clear, even during the summer, that there would be 3 separate tranches of flu vaccine delivery during the course of the year.
I think practices are aware of their list of vulnerable patients, so they're aware of their list of over 65s. And actually, most practices order their flu vaccine months in advance. We've all ordered them. When we run short before a planned flu clinic, we often contact our neighbouring practices to see if we can use some of their supply. But actually, they haven't got any to hand over this year either. So the issue is actually across the whole of the community, rather than just in individual practices.
So, as I say, I'm more than happy to work with you or a group of practices if they're experiencing that. I haven't been made aware that there was an inability to source within our localities sufficient supplies of vaccine in a timely manner. The assurance I've had when we've had that crop up in other practices, we've been able to sort it out within a very short period of time. But I do accept I'm sort of hostage to fortune as to what NHS England have as their central strategy about the 3 planned releases of vaccines. I would imagine they're getting that feedback from more than just ourselves.
So I think that there's a national picture on this as well as a local picture. I do think that there was a letter that was sent out by NHS England which actually covered the points that Fergus was making, but it might be pertinent to actually send out an email to each of the individual practices to find out what level of difficulties that they're actually getting at during this supply time, so that if there are practices with availability of vaccines, that they could then be put in touch with practices who have got a shortage. So it may well be worthwhile just sending out a quick email shot to the practices just to find out if it is a general problem right across Kingston area. Okay, any other comments or questions, Nadeem? Oh, sorry, Catherine first, Nadeem. Sorry.
It was just a comment around the children under the age of 5. It was around the comms and engagement and the bit around the priority. And people are mindful that if you look at health visiting services, it's the bread and butter looking at under 5s in particular. I'd just like to see that a little more explicit in terms of that diversion and prevention, because they're very much at the heart of delivering that child health service, and also children's community nursing teams who might see children who might have more chronic conditions and actually might be seen as more vulnerable.
Thank you. Very happy to take that forward. As Naz has indicated, locally Your Healthcare have been key partners in our delivery of our A&E Delivery Board winter plan, but also our key partners in terms of the support around our communications and communication strategy. But certainly the children's community team and health visitors, we can make sure that we link that very clearly to what we're doing for the under 5s messages.
Great, thank you. Nadeem.
Just a question about the priorities for 2018 and 17. The pre-Christmas period from 12th to 21st of December is fine, but post-Christmas, starting from 2nd of January to mid-February, I would say by 2nd of February, the battle is already lost, because by that time, hospital is full of patients who have not been moved out of the hospital, because all services will come to a close by lunchtime on the 21st of December and reopen on the 2nd of January. So where the support, actually more intense support is required for in terms of discharging patients and moving out, is really a period between the 21st of December to the 2nd of January. Otherwise, what you'll find is by 2nd of January, the hospital is just full of patients who perhaps should have been discharged a week or a few days earlier.
So rest assured, when we're talking about Silver Command, that doesn't mean during the periods where I've not listed within this that we don't have a robust on-call and senior manager presence, certainly within the trust and also with partners as well. 365 days a year, 24 hours a day, there is an on-call director for the CCGs, there is an on-call director for each of the providers and their partners. Our experience in the local system is that generally they cope quite well through the Christmas period, and in fact very often on Christmas Eve, Christmas Day, our bed availability within the trust is significantly better than it is for other parts of the year. In part driven by the elective capacity, so people having planned procedures, very often they're not that keen to have them on Christmas Day or Boxing Day, and we adjust the schedules accordingly. Our support around delayed transfers of care, I think in the Kingston system we have done extremely well in that regard. So on a daily basis we are aware of every single patient and what the causes of delays are and what the steps are that we should take to support those patients. And I think what we're highlighting within this in terms of Silver Command, so that will mean people like me or my level in other partners will be physically on site with the hospital or available at the end of a phone call which is answered to help navigate sometimes for the patients who are out of area. So it might not be good local relationships or connections with people from Merton or Sutton or beyond into Surrey areas. Part of my role would be to help support some of those channels of communication. So I think we're highlighting that we'll have an extra level over and above what would be the normal management approach that I think most hospitals would have. And we've put that resource in for not an inconsiderable amount of time. It's getting on for 2 months of very operational work. I'm happy to, we will respond if there are pressures in excess of what we expected. I'm happy to respond, say that we will respond and manage that as that presents itself.
What I was saying was that most services go to on-call or emergency level only between Christmas and the New Year, which is where the problems tend to arrive. So it's not that services are no longer there, but social services and everything else, transport, everything else is actually working on a skeleton staff between that period of time, which is where the problem builds up. So there's a good 10, 12 days where the problem is just gradually building up. So by the 2nd of January, it's got to the stage where the whole hospital, the whole healthcare system is oversaturated with the patients. And is there anything that could be done to get to that stage? So that I think the more intense support and more patient transfer should be happening between Christmas and the New Year, then you won't have such a big problem, which we get every year in winter period.
So I think it was not to say that this is instead of, it's to actually put on top of an already quite heightened ability to respond to inpatient services. So Tonya, did you want to come in on this?
Sorry, we've been working in the system on these issues for a number of years now, and I have seen a change. And you're absolutely right, when we started on this journey, you know, services used to close down over the Christmas period. Actually, you know, those those working days between Christmas and New Year are working days. So we don't have the same issue that we had 2 or 3, 4 years ago, where, you know, social services wasn't there to do the package of care, they weren't assessing people. Of course, you're not going to have a full complement of staff over the winter period, but one of the points of the A&E Delivery Board is to keep challenging our partners around what capacity they are putting in those peak periods. And as you say, we got an opportunity through between Christmas and New Year to move, you know, safely move patients through their pathway. So I absolutely recognise what you're saying. It's something we do have to keep an eye on, though I think we've, as a system, and through the A&E Delivery Board, we've been doing this for a number of years now and recognise the need. And I think we have in place more robust services through the Christmas period that enables us not to have that problem. As I say, you can't always predict what's going to happen, but I think there has been a mindset change in how services run through that period.
And if you look at the numbers of detox that have come through over the last year, even year, 18 months, the improvements across the whole system have been phenomenal. The amount of integration around delivery of the services in the community to try and support these patients being discharged has been really quite robust. And I would not see a difference with them being able to provide a Christmas to New Year service, because it will still be working days during that time. So, Fergus, was there anything else you wanted to add to that?
Well, so I guess some of those teams, like the joint agency discharge team, again, they're working 7 days a week now. That includes community partners, it includes social workers working 7 days a week. And as Tonya has importantly pointed out, you know, our ability to restart packages of care or assessments to get people into nursing home placements, if that's the right thing, I think it's much more of a 7-day service or a 6-day service than it was 2, 3, 4 years ago, when it would have been much more like a 5-day service. But we recognise Christmas is an important period of time. A big part of our focus is making sure that people are in the right place. Getting people home in time around that time of year is a key driver for lots of the clinical staff. But we can be responsive if things are not going as we have at least planned for, which is where we're at this stage.
Great. Any other comments or questions from board members? No?
You stole my thunder actually, because I've never done.
So I think generally there is a feedback to be provided back to NHS England around this, which I think is what we're going to collate at the end of this. Okay, Richard, you want to come in?
So thank you, Richard. That's really helpful feedback. I think one thing which I didn't mention in my presentation was we've got a meeting with the 5 local authority health watch groups that the chairs that meet at the hospital on a quarterly basis. We've got an opportunity to share with them our winter plans. I think what we would want to use groups such as you've identified are about some of the communication strategies around the self-help, the flu, using 111. The detail of the plan is quite operational in terms of what we as a system might do, but I think there's some important communication messages that I think we could take forward with you.
What you want.
More than happy to take that point.
Okay, thank you. All right, unless there's any other questions, we'll move on to the health and care plans. Julia?
Lovely. Thank you, Chair. All right, is that better? It's the plan that we're developing as a CCG with local partners on behalf of the Health and Wellbeing Board with the Council, voluntary sector and local people, which is all focused on where health and care coming together can maximise the outcomes and improve health and care for local people and reduce health inequalities. The plan is part of an iterative process, and what I'm presenting today is the work to date around the work we've done on the case for improvement, which is actually what do we know about the health and care of our local population and the priorities that are emerging. And then what I've done is I've aligned the commissioning intentions for the CCG, which we saw in draft form in September, along the lines of the local health and care plan. The plan is due to be published in March next year. Some of that might be dependent on the publication and the timelines associated with the 10-year plan, and the fact that we need to now, we'd be as part of that, we'll be asked to produce a South West London-wide system plan, 5-year plan in the summer. If I take you to the presentation slide pack, and apologies that some of the text is very small, but there was lots of information that I wanted to get down into the presentation. As part of our role as a CCG, we are responsible for the continuous improvement of healthcare for our local population and reducing inequalities. And annually, we will inform our local providers, local patients and the wider public of our intentions with regards to service changes, service transformations, investments, etc. And those are our commissioning intentions. As part of this year, we have also we've merged them together with the work we're doing around the delivery of the local health and care plan, which, as I said, is about how health and care, meaning the council, social services for both children and adults, come together. And what the plan really is beginning to show is how we are working in more collaborative space together to improve care for our local patients, but not only as commissioners who have the funding to commission the care, but also with providers. The local health and care plan is a 2-year plan. It's based on the feedback that we've had from local people, so insights, and we do value the various groups that we have spoken to date and we will continue to talk to, and any new groups that are around thinking about what, Richard, your offer for the groups at Kingston Hospital were most welcomed. The other key component part of formulating any changes in services, developing services, is to use the strategic joint strategic needs assessment, which is developed by Public Health, which really outlines the health and care of the local population, where we are good in terms of health indicators and where we could do much better. And so that's reflected in the plan further on. And as I said, it's about focusing on what will improve health and care for the local population. Like our commissioning intentions, the local health and care plan also is all age. It's not just looking at the lens of children or the lens of adults. And actually it's using the themes of start well, live well, age well, and taking us through sort of, I suppose, it's taken us through the life course. And it's drawing on a lot of the existing work we've already been doing and putting that together. As I said, it's an iterative process, and some of the language, particularly around the priorities and perhaps some of the wording of the commissioning intentions, could be more refined and less medicalised, less clinical. But as I say, this is a process that we are working through. And we do have the event in November, which we heard about earlier, that people have been invited to comment on those priorities, but actually will also, there'll be other opportunities to also discuss and share them as well. The presentation talks about what local people have told us about what they do and don't like services, and I'm not going to go through that. And it also picks up on some of the quality and performances of our local providers. And we can see that Kingston, as our local district general hospital, rates overall outstanding by the CQC, and South West London St George's, our mental health trust, actually rates good. And similarly, our community provider, Your Healthcare, which I've missed off, so apologies to them, in just looking at the quality and performance of local providers. And we have a number of local strategies that we've developed and are developing. But one of the key things, and one of the key ones, which is underpinning and overarching, is our approach to integrating care under the Kingston Coordinated Care, which we started work on in 2013. And what I've just included in the pack is the two lenses of that, which is around supporting the development of active and supportive communities, which is about building our community resilience, our community capacity, and actually the community responding and supporting people. And then that where people need individual, personalised, patient-centred care is where we are actually having personalised care plans that focus on achieving improvements in quality of life, the goals that are important to them, but also moving towards a more proactive and preventative approach. So that sets the frame. So then I'm going to move on to our commissioning intentions. As I said, these are done annually. And are very much focused on what we're going to be delivering in 1920. And the Local Health and Care Plan is going to be a 2-year plan for 1920 and 2021. So what we will be seeing as part of delivering the Local Health and Care Plan is some of the local commissioning intentions also reflected in that, where, again, we're working with health and care. So the first slide, which is the busy blue slide, actually shows that prevention is important and runs throughout the themes of start well, live well and age well. And what I've just summarised in that first table is those areas which are key indicators about our local health and population in terms of, and our framing what is our case for change, our case for improvement. So it identifies that 29% of our 10 to 11-year-olds are overweight or obese. And that actually we have 2,700 children with special educational health needs. So it's picking up those areas, and then those themes from the case for improvement then flow into the priorities that we've identified. And so I've got a number of working documents. So these are just headlines which I've summarised into 2 or 3 key areas which actually build up the pictures. And then what I've also identified for and pulled into the plan are the areas, or what we expect to be the improvement for local residents in terms of working in these areas. So if we're going to maximise or improve the mental well-being and resilience of our young children, that will support them being able to have more independent, more fulfilled lives and citizens later on. So for each of those areas, I'm not going to go into them. I've talked about start well, live well, age well, case for improvement, the priorities that have emerged in the local health and care plan, and then the areas of impact. So that's the local health and care plan. I'm then going to move you on to the commissioning intentions. What I have then done is I've taken the commissioning intentions that I shared in September and have used those and aligned them to the health and care plan, start well, live well, age well, where they're applicable. So across the children's services, you'll see a whole range of activities that were in the commissioning intentions related to improvements in services for children and young people. And one of the key areas, which I think we picked up earlier, is around the pre- and post-diagnostic support, particularly for those on autistic spectrum and those with ADHD. So we are recognising that that whole pathway needs improvement, and we need to be doing more work around that, and also our early intervention and prevention service for 5-year-olds. In Live Well, we've picked up on the importance of having the integrated care working to support people with complex health and care needs, picking up on the whole aspects of bringing mental health and physical health together. And also at this stage, we're also looking at people with learning disabilities having transitioned, as have children from disabilities, from being children and young people. And then Age Well is very much focused about experience of living with ill health, isolation, and then also looking at good end-of-life care. And then there are some other commissioning intentions that link specifically around urgent emergency care that cover all ages, planned care again that cover all ages, and primary care. And there's a lot of work we've been doing locally about building and shaping our primary care services locally. So what I've done therefore in this document is really is to align the thinking and show the coherence and the synergy and the linkages together. Say this is still iterative, and comments are appreciated. Very quickly, I'm just going to move on. Say, as part of the process, particularly in delivering the local health and care plan, there is a whole range of engagement and partnership working that we're undertaking in the development and the further development of the plan. And therefore, any comments, inputs are more than welcome. We've got the event on the 21st of November, but that's not the end. We will continue to come out and talk to various groups and have various forums where we can work with local partners to continue to develop the plan. Because once we've agreed the priorities, we will then move into what are the actions that are going to deliver those priorities and how are we going to measure the success and demonstrate impact, and it's very important that that is informed by local people's views on what would look good for them and the outcomes. And then the other next steps are really linked into the commissioning intentions in terms of the commissioning and contracting business round, whereby we're responding to our commissioning intentions have been shared with providers such as Kingston Hospital. They're coming back to us and giving their feedback on that. They're giving us their intentions and we're feeding back to them. And we're also waiting for the national timetable in terms of the publication of the operating planning guidance, which will set the framework, for next year's financial position and the activity, linked into the conversation we had earlier about the elective delivery. And we will then go formally into negotiations with local providers. So I think I've said enough. Would welcome any comments, feedback, and questions on the pulling together of the local health and care plan and the commissioning intentions. Thank you.
Thank you very much, Julia. There's an awful lot of work behind this, and actually this is not new work. This is work that's already existed, and we're trying to bring it together to actually show a very cohesive way of our plans, both over health and care, and trying to support patients and public going forward over the course of the next couple of years. So any comments or questions, Catherine?
Thank you. It was just under the urgent care, Julia, under the commissioning intention, the expanding the community IV antibiotic services across Kingston. I was just going to add a little further to that, and also it is a way of one of the barriers is allowing sort of the senior district nurses to be able to undertake the courses, so therefore they have the right skills in order to be able to deliver that. And there have been some issues nationally for those nurses being allowed the time in order to be able to gain access to training that sometimes is held up. There's lack of numbers and so on. The other aspect of that, I think, that would go align with that is around non-medical prescribing and really supporting the district nursing teams so that actually, and I know this is happening across England, so that they actually have the right skills in order to be able to deliver a much more complex service to much more complex patients, which includes IV therapy as part of that. So it was about how we kind of support that so the teams can then actually get the right skills to be able to deliver that.
Okay, thanks, Catherine. And I think it's something that we need to work on as we're having discussions with your healthcare when we're talking about the healthcare plans. So any other comments or questions, Gareth?
Thanks, Julia. There's a huge amount of information there, and it's been put in a very readable document, which is really, really helpful. There was just one point I wanted to just add about the Live Well. We talk about reducing health inequalities, and you've mentioned particularly people with learning disabilities, serious mental health, or multiple long-term conditions. I just wonder whether we could put something in there about the BME groups, because we know they already have a higher prevalence of significant chronic diseases such as ischemic heart disease and diabetes, but also particularly low rates of cancer screening particularly, and we're lower than the average for that anyway, and I wonder whether we could maybe add that group in there.
That's great, thank you, Gareth. Any other comments or questions? No. Okay, anything from the floor? No. Okay, Julia, thank you very much, and thanks for all the work that's been going on from you and your team to actually start pulling this together. So we are going to get further iterations of this as the engagement piece goes on, and so we'll be able to get a refined document coming out over the course of the next few months. Okay, thank you very much, Julia. So if we can come to the BAF, Tonya.
Yes, unfortunately, Vicky can't be with us today. She's not very well, so I've agreed to present the Board Assurance Framework paper. Members will remember that the ownership of the Board Assurance Framework sits with the governing body, and twice a year we do a deep dive review of the Board Assurance Framework. That's in March and September, so the paper you have today is a summary Board Assurance Framework report, so we're not doing the whole deep dive this time. The Board Assurance Framework is formed from risks pulled through from the corporate risk register. There are several lower level risks in addition to the ones reported here that are currently on the register, and they are being mitigated and monitored through the committees of the governing body, and it is the executive management team that is responsible for the oversight of the risk management process and reviews oversights of all the risks on at their monthly meetings. So in summary, we are reporting 28 risks that are summarised in this report. There are 2 very high risks, and they are case 7, which is failure to meet some of the national performance targets, and case 16, potential overperformance in acute services, which could jeopardise the ability to meet statutory financial obligations. There are 17 high risks, and you wouldn't be surprised to know that some of those high risks relate to some of the items we've discussed today, particularly winter. So if you look at the summary, winter, though we've got a very good winter plan, still remains a high risk for the CCG and the system. So that's a really broad, very quick canter through a summary of the board assurance framework, but I'm happy to take any comments or questions.
Okay. Any comments or questions around the BAF to Tonya? No? Okay, thank you. I think one of the things that was quite good is actually seeing the trend bit as well, so the direction since June. So I think that was really helpful as well. Okay, thank you. So if we can come to the commissioning papers. So IGC report. Did you want to take this, Fergus?
So myself and Phil will do a double act on this one if Phil wants to add anything at the end, but I'll start off if that's okay. Thank you, Chair. So this report includes the South West London performance report as well as our more local information in Kingston CCG. It contains a summary of our latest performance assurance, our improvement and assessment dashboard, and also our quality premium dashboard. On the cover sheet, I've highlighted where we are and how we're performing against some of the highlight constitutional standards. And you'll see of those, we're doing quite well against a broad range of either referral to treatment, cancer and psychiatric services targets. And as we've mentioned already, we have a continuing challenge around our accident and emergency performance. So the key points that the governing body is being asked to note is listed then on page 2, which covers our accident and emergency performance, has yet to reach the 95% standard. Our mental health improving access to psychological therapies performance remains good. Our dementia diagnosis rates remain challenging for the CCG, and I've provided some more detail in that about the work that we have done at the last Integrated Governance Committee around a refresh of our improvement plan in that area. This has been proven to be one of those wicked areas, I guess, in terms of our ability to address the underlying issues. I'm pleased to report that all of our referral to treatment targets and diagnostics targets are being met, and all of our activity performances within the operating plan expectations, with the exception of the GP referrals, which are above plan. So going through the report itself, on page 5 you'll see our overall position against constitutional local standards remains overall very positive. There are a number of areas that I've picked up within the report then that I'll come on to. So in terms of estimated diagnosis rate for people with dementia, we have been failing to deliver against this national target for quite a long time now. We had a very helpful presentation from some of our colleagues in frontline action to improve this area, and we have received an updated action plan from them, which we'll continue to monitor through the Integrated Governance Committee. I think one of the concerns we talked about at the committee was whether or not we really can identify the people in the volumes that are expected to within the national prevalence, and I think, Phil, maybe if there's something that you'd want to add at that point in time to that.
The only comment I want to add to it is we had the dementia team from NHS England London down, and actually they had no other suggestions apart from the things we are already doing, which I think was encouraging. But we have seen our dementia diagnosis rate slightly reduce every month for the last 8 months. So not quite sure where the people are, but we're going to make every effort to try and find them.
Thank you. I've touched lightly already on our referral to treatment and diagnostic rates targets. In terms of mixed-sex accommodation breaches, there is a breach that I reported back in June. We still haven't received a report from Imperial Trust around the broader mixed-sex accommodation issues there, but we are planning to pick that up again at our next Integrated Governance Committee. In terms of healthcare-associated infections, there have been 3 MRSA healthcare-associated infections for the year-to-date in August. Each one of this is reviewed by the Commissioning Support Unit to understand the underlying issues and identify whether there were any lapses in care. And we did have a further deep dive into our Clostridium difficile rates at our most recent meeting as well, where, as I reported previously, we're seeing higher than we would normally have rates locally. We're experiencing that across South West London and indeed the wider London area. But we haven't been able to identify any specific issues in our locality, either in terms of practice or incidents, that would help us to target some actions more than what we have done so far. So we'll continue to monitor that. There's a useful section which just covers off some of the accident and emergency performance, and I think I've covered most of that within the winter plan. And then on page 10, you'll see a summary table covering our operating plan supporting activity. And the area that I've teased out within this for more information for the governing body is that particular issue around the growth in GP referrals. And as has been previously mentioned in earlier discussions, we are continuing to see a reducing level of overperformance in that area. So while it was running at 6.3% in July, it has dropped to 4.3% in August, and the early figures for September indicate that that's improving or continuing to improve.
Absolutely.
I have previously talked about the improvement and assessment improvement and assessment framework dashboard, which is covered on page 11. I don't think there's anything new within the report that I would want to mention. In terms of the quality premium dashboard, you'll see from that there are some areas that we still have some improvement to do, principally on the continuing healthcare performance, which we had some challenges over the summer period with our staffing, but also the number of patients on the incomplete pathway, this OTT issue that we talked about in our earlier presentation. And then finally, on the last page, we have received at the Integrated Governance Committee a range of reports from providers. There are no particular issues that I'd want to draw to the governing body's attention today. But unless there's anything else I've missed, Phil, I'm more than happy to take any questions.
Sorry, Sarah.
So I wondered on dementia diagnosis, because this has been a long-standing problem in Kingston, and Kingston stands out as being a long-standing problem across London, whether or not the governing body ought to receive a deep dive on what we have done and show all the work that's happened, because I think, we have to be able to evidence, I think, at governing body level that we've done everything that we possibly could. I'm not suggesting we haven't, I just think we need to bring it to this level just to evidence that, should we get asked as well. Because it's just something that we just don't seem to be able to crack. And I think that we need to evidence all the work that you've done with the London team and everything else just to show
We have presented that to the London team. Very happy to present it here.
Yeah, I think it would be helpful actually for governing body to have sight of that, because of all the performance is good in Kingston on nearly every area, and this one just seems to be impossible to manage.
So I would offer that we circulate to the governing body the paper that we received at the Integrated Governance, which I think will cover off some of the suggestions that you've made, Sarah. And I think what would be most helpful is if then members have specific questions or things that we'd like to answer by way of a presentation at the next governing body, then we could prepare for that as well. So if there's something that we have failed to think of that our collective wisdom might offer, then really happy to try and use our time in that way.
Yeah, and I'm not suggesting that we'll suddenly come up with the answer. What I'm saying is that that's part of the assurance process to say, actually, we've done everything we possibly can.
Great, thank you very much. Okay, thanks, Fergus. Catherine.
It was just a comment really that I just noticed that under the vacancy turnover remains an issue for the 1-1 provider Vocare, and obviously that features quite strongly within the winter plan. And I just kind of wanted to I'm sure that you're mindful of that. It was just looking at how they were kind of looking to try and ensure that if you're going to direct a lot of people that way, that they got the capacity in order to meet that demand.
I think that's a fair challenge. I think within the detail that we have within the winter plan, there are a range of, in some cases weekly, but certainly fortnightly and monthly monitoring approaches that Jonathan Bates, one of the South West London Alliance directors, takes a lead for on behalf of all of the CCGs in South West London. I note your concern. It has been a challenge for them. I think there have been points in time where we've seen that performance and indeed their fill rates have improved, but I think that will continue to be a challenge over the winter period, but note the concern.
That's great. Any other comments or questions around the IGC report? Rob. Thank you. Okay, there are alternatives to actually diagnosing as well, rather than the memory. Yeah, no, I completely agree. Yeah, thank you, Rob. So if we can come to the finance report.
Thank you. Okay, so the report that you have in front of you is the month 6 report that went to our Joint Finance Committee last week on the 30th of October. I'll come on to the month 6, but I'll just give you a brief update. We received a initial planning letter which detailed some of the planning intentions for 1920. I think it's fair to say, actually, it was quite confusing, some of the intentions that they wanted to cover in a one-year plan, and they wanted to look at a consultation on national tariff, and they also wanted to look at how that might impact on our allocations. I suppose the alarming thing for us is, whilst this is going on, we are still held to quite a tight timetable. So our allocations should come through in the middle of December. Invariably, they're a week or two late, so we tend to get it as a Christmas Eve allocation. But the first draft needs to be ready by the 14th of January. And the tariff discussion is going along parallel to this, and actually the outcome of the tariff will not happen until after that date. So I think there's quite a lot of things that are up in the air. I suppose the positive part of it is that it is gearing us to work more collaboratively together. So actually we are working quite closely with Kingston Hospital, because I think it's a shared feeling of uncertainty. So actually working together on this could be setting ourselves the foundations that we need for 2021 onwards. So there is some positive from that. So if I can just take you through the month 6 report that you see here. I'm pleased to tell the governing body that we are on target to meet all our business rules. We have seen a small increase in pressure in the acute sector, specifically at Kingston Hospital and the Marsden, but at present we have reserves to enable the delivery of our forecasted surplus of £1 million. We have seen also significant pressure at Guy's, but actually that's from a non-recurrent critical care patient that we've seen there, so we don't anticipate that cost to increase significantly from there. In terms of the non-acute position, again, we are seeing pressures that we've mentioned before in terms of mental health placements and children's placements specifically. But we are seeing that the non-acute position is balanced out by a well-performing continuing healthcare placements there. In terms of primary care, at the time of writing this report, we were advised that there would have been prescribing pressures coming through for category M. Since writing this report, we've had feedback through the EPAC system that actually the pressures that we thought we might be having will not transpire this year. So actually for month 7, we're expecting a more improved position in that area. if I can take you to slide 17, the risks and mitigation slide, you can see that the current reported position is on the left, and we've tried to work through any unmitigated risks on the right. So we are looking obviously at potential further overperformances there, but at the moment we have enough mitigations in terms of contingencies held to cover that position. I suppose the only thing that I would add is that from the BAF, the BAF paper that Tonya brought before, I suppose we need to update for the next meeting to bring that down from very high to high. So I'm happy to take any questions.
That's very helpful, Yalini. Thank you. Any comments or questions around the finance report? No? Okay. All right. Thank you. Atin, do you want to give us a report about the council of members?
Thanks, Naz. So the council of members has actually met twice since the last meeting, but the October minutes haven't been formalised yet, so I'll just report back on September today, if that's okay. So we began with the members' issues, amongst which we were provided with an update on the conversation between the social workers amongst the multidisciplinary teams and GP practices. This was born from concerns about inappropriate home visit requests and delegation of certain non-clinical tasks coming back to general practices. Annette has been in conversation with the team leaders amongst the social workers and involved in workshops where these issues are being addressed, I understand. The members received an update on the ERS system, which went live obviously a few months ago. Appears to be working well in certain areas, such as routine referrals and 2-week referrals. However, there has been an area, a gap noticed in where patients need to be referred to the hospital urgently to be seen within a matter of days. And those can't be processed through the ERS system. So that was raised at the council members, and examples are being sent through to the ERS team for that. We welcomed Alex Lang from the Health Innovation Network, and he presented a mobile ECG device which ties in quite well with the one of the opportunities identified through the NHS Right Care programme in detecting atrial fibrillation in the community. It doesn't need to be a doctor that uses it. It can be done in waiting rooms or pharmacies. The council members were happy to trial those devices, and since then they've now been rolled out to GP practices, so we should be using those imminently. Jackie Walters gave an update on developments in the end-of-life care and received support from the council members to continue developing partnerships between the community and healthcare services with a particular focus on developing good quality and shared clinical notes in this area. And finally, Catherine McDermott gave us the primary care update focusing on the practice data packs with referral rates, kinesis and ERS usage. Thanks.
That's great. Thank you, Atin. Any comments or questions for Atin? No? So if we can come to the Kingston Richmond End of Life Care Strategy, I know it's a big piece of work that has been going on with the strategic group that meets on a regular basis. So Julia, do you want to go through this? This is for ratification.
Yes, I'm pleased to bring to the governing body this afternoon the final draft of the Kingston Richmond End of Life Care Strategy. We've been working on this collectively across the system because we share Kingston Hospital in common and also Princess Alice Hospice, who are significant partners along with community, social services, voluntary sector and other in supporting and working with people at end of life and actually people needing support towards end of life. So this is a strategy that's to cover the period 2017 to 2020, and it's all about improving the experiences for patients and relatives in terms of end-of-life care and actually reducing the inequality, some of the inequalities and variations of care that there are. And one of the areas that, and the plan covers all the different areas of work that the end-of-life care strategy will undertake over the period 2018 to 2020. If I take you to the presentation within the pack, it gives some facts and figures about the percentage of people who die at home compared to dying in a hospital. And then it talks about the areas that we want to improve. And a lot of this is about better coordination and cooperation working between partners. There is also something about improving education and training, because it's often about having those difficult to have conversations with individuals and families, actually, when they are identified as potentially coming towards end of life, and actually the importance of planning. There's also the support for carers, and there's also access to good end-of-life care across the range of partners. So they're focusing on 5 broad objectives. There's about compassionate community development. I've just heard this afternoon that a bid that we put into Macmillan for the development was unfortunately unsuccessful. So the team are now looking at how else we will move forward in terms of developing our compassionate communities. The whole focus around person-centred and holistic advanced care planning, and the importance component of that, of course, is the Coordinate My Care record, which is an electronic record that is available on an e-platform for everyone to see. So if someone goes into hospital and there's a Coordinate My Care plan, that can be seen by the hospital, that will be very clear about what an individual's goals, wishes and desires are in terms of the management of their presentation and or their choices at this critical time. It's also about improving the experience. It's also, as I say, reducing inequalities, and it's also to help us effectively commission. The outcomes are, as stated, about supporting people to live well in a way that they want to when they're approaching their end-of-life care, but also the provision of after-death bereavement to those that are still there in terms of family, friends. It's about receiving good quality coordinated care and dignity and peaceful death. And it's actually building resilience within the community. So the report, the development of the strategy has been through many iterations. It's been to the governing body membership. It's been through a steering group which has wide and varied membership. And so it's really coming to the board this afternoon to be approved, so we can then move into the next stage of actually taking forward the implementation and working to deliver the priorities. And you will see that end-of-life care is one of those priorities that's reflected as part of our local health and care plan. It's come out of one of those joint priorities and is a priority within our commissioning intentions. So this strategy is supporting and the development and delivery of that plan. So I commend the plan to the governing body and seek their approval, please.
Right, Sarah.
So I did say this in Richmond, and I'll say it again because I think it's an important point. I think we'd all aspire, and I think it is an aspiration around compassionate community development. I think the question is, how will we do that? Because that's a fantastic thing to aspire to. What I'm not clear on is, number one, how we will do it, and number two, how we will know we've done it, because it's quite a difficult thing to measure, isn't it, to say we're getting compassionate care. So some of this is very clear that you can actually count it, or you know that it's happened, but I think we might need to think a bit differently about how do we understand what and how and if.
So as committed this morning at the Richmond governing body, what I'll do is I'll take that back to the team who are overseeing the implementation of the strategy to actually have a discussion about how are we going to develop that and how are we going to make sure we've got the right evaluation and measures in place that demonstrate that actually we've achieved what we've set out to achieve in terms of that outcome and priority.
Okay, thank you, Julia. Jim.
I was going to ask a very similar question, actually. I mean, I found this a really interesting read, and it's a conversation we haven't had in any detail during my time on the governing body. But it did seem hugely ambitious, slightly poetic in places. And I wondered if you had to sum up in 2 or 3 sentences, what are the key changes in approach that this strategy will signal to us and to providers and to consumers? How would you describe that? What's going to change?
Well, this is very personal, and for me, this would be about having those those conversations at the right time. It's ensuring that those who are caring for you are coordinated and know what that conversation is and what those desires and wishes are. And then at the end afterwards, that there is the conversation with those who were caring for the individual, but also be it a relative, be it a carer, be it the formal carers coming in, there is then some feedback mechanisms that actually says, was it a good experience? So it's the outcome, it's an outcome measure, but it would not be the person's outcome, it would be the family and the coordinator care. So that to me would be what I'd like to see come out of this. But I'm less...
And I think underpinning all of it would be respecting the patient's wishes throughout this whole journey. So, Annette.
And I think actually that the key change in day-to-day practice will be far more advanced care plans being created, because it is there that all of that is stated, and therefore that the patient's wishes can be, and in drawing up those those advanced care plans, you also have those conversations, and that's the actual change, Jim, is those advanced care plans being drawn up more frequently, in a more coordinated way, and being therefore shared more widely, because they are created just by their being, and therefore for care to improve and outcomes and experiences to be better. I think that's the practical outcome.
And we will have confidence that those advanced care plans will be shared across any provider that the patient comes in contact with.
So if they are Coordinate My Care plans, they can be accessed by all health and care professionals in the borough, yeah.
So I think just in as addition, members of the audience are actually here from Devonshire Home, where they do promote Coordinate My Care, and the patients that are actually signed up to it actually have their wishes adhered to when ambulance services, NHS 111, hospital services are actually in touch with that patient. So the patient's care is actually coordinated particularly around the patient's wishes. Sorry.
So I think there's a couple of things. One is this is hugely important. This is about how, not just about how we deliver services, but how we support individuals and families through what can be a very difficult time, but to live, and it's the end of the, live well, what's it called? Start well, live well, age well, and yes, I think that's really important. I think what we need to do is be really clear about what's it actually going to mean on the ground, so that we can really get those things into place, because it is so important. So I think that's, and just on Coordinate My Care, one of the big issues, so I'm actually the lead for London on Coordinate My Care since a few weeks ago, lucky me. But one of the big issues around Coordinate My Care is just making sure that we actually put those plans into place and making sure that they are real and they work, because I think once they're in place and they do work and they can be accessed from every part of the system, but how do we make sure that people are using them in a way that makes sense, actually putting them into place, I think.
That's great. Catherine.
I was just going to make a comment around naming it in terms of start well, live well, and all, but actually that we name that it's end well, and that we have that in the title, because actually if you think that the kind of upstreaming, it's about having a conversation in advance and keep being open and transparent about that. And I think around the advanced care planning, it's around the conversation you have with that individual, so that it is recognising there's a range of professionals and others that you may be having these conversations with around advanced care planning, and that kind of, sets the scene for who might be involved in a wider way in terms of that plan.
That's great, thank you. Okay, any other comments or questions around the life care strategy? Name.
Julie, Appendix 1 is the current services in the area, yes. And on the bottom of page 24, there should be a reference to Kingston Bereavement Services. It doesn't seem to be there. They provide a very valuable resource locally.
Okay, thank you. Any other comments or questions? All right. We'll take a comment from Rob.
that now, so I made it.
Okay, that's really helpful, Rob. So if we can just take that away, maybe have a chat with the local authority as well. Thank you. Okay, thank you, Rob. Okay, so the governing body are asked to ratify this. Are we happy to ratify? Yep. Okay, agreed. So if we can come to the minutes for information. As regards the Primary Care Commissioning Committee, is there anything else you want to add, Jim?
Well, just to say, again, we've had a subsequent meeting at the beginning of October where we had some busy conversations, particularly around primary care at scale, where we had a further iteration of the proposal for how we spend the money that has come into primary care in Kingston in terms of supporting locality working and some coordination across admin, across general practice, as well as talking about e-referrals and DXS updates.
Okay, great, thank you. There are minutes here from the South West London Collaborative Decision Making Committee in common for information. As regards recent policies approved on item N, there's the Kingston Richmond CCG's risk management policy that had been approved. So that's for information there. As regards any questions not pertaining to items on the agenda, is there anything from the public that want to say anything? No? Okay, so if we can say that the next meeting is on the 8th of January, it's be based here. And if we can just have 5 minutes before we then go into a part 2, if that's okay. And it'll be in the back room at the back again. Okay, thank you very much. Thanks.